Initiative. I'm delighted to welcome all of you to the first session in a series that we are calling Building Our Toolkit for Local TB Elimination. The objective of this series is to create a space of shared learning and reflection that is rooted in the collective actions of the Zero TB Initiative. This is an alliance of local coalitions that are each working in a defined geographic zone to more rapidly reduce tuberculosis there, in that place. These coalitions are creating islands of tuberculosis elimination, one community at a time. This year, to promote exchange and shared learning, we are going to hold a series of webinars with two types of sessions. Some sessions will review the key concepts and strategies that form the basis of local TB elimination, and other sessions will be about the experiences of specific coalitions using specific interventions. Again, the goal is to promote exchange of experiences and shared learning. Now, for each local coalition in this alliance, one of the essential tools in their toolkit is preventive therapy. And today we're going to hear from one coalition that is truly at the vanguard in using this essential tool. They are Drs. Hamida Hussain, Amin Malik, and Maria Jaswal, representing Interactive Research and Development, the Indus Hospital, and the Indus Health Network. You can read more about each of them in the biographies posted with this video. Once you hear their presentation, I hope you'll agree that this experience is invaluable far beyond Pakistan, because it raises irrevocably our collective expectations for what is possible in each of the places where we work and where we call home. To advance our shared learning, after you listen to this recording, we invite you to also join the live question and answer conversation with the presenters that we will be holding on April 8th. And the link to register for that session is also below. Again, welcome all. Hamida, Amin, Maria, thank you for talking with us. You have the floor.
Hi, I'm Hamida Hussain. Thank you very much, Mercy, for those nice, kind words about Pakistan and the program. So today I'm going to talk about Pakistan's program on preventive treatment for persons exposed at home to drug-resistant and drug-sensitive tuberculosis. And the floor is going to be shared between Maria, Amin, and myself. We have divided our talk into 4 parts. The first part, I'm going to set the scene and talk about the Zero TB initiative that was undertaken in Pakistan. Then my colleague, Dr. Maria Jaswal, will come in and talk about the drug-sensitive tuberculosis and prevention treatment for it. And Dr. Amin Malik will then come and talk about the preventive treatment for drug-resistant TB. And lastly, I will have the floor again, and we'll talk about the impact of these interventions, as well as the cost and the cost-effectiveness of systematic household screening and the preventive treatment. First, Pakistan is one of the high TB burden countries. It's a very large country with a population of 217 million. Annually, about 570,000 people develop tuberculosis, of which 25,000 have drug-resistant tuberculosis. Unfortunately, only 58% of the cases are detected and initiated on treatment. It is in this setting that IRD, an organization to which I belong with, started working with its partners on the TB program. IRD is an organization which primarily works in Asian and African countries under the portfolio of maternal and child healthcare, infectious diseases, global surgery, and non-communicable diseases. So IRD partnered with the Indus Health Network and Indus Hospital, which provides quality care free of cost to its patients to initiate the TB program. Both these organizations in 2007, in collaboration with the National Tuberculosis Control Program of Pakistan, started the private sector initiative where the patients were treated in the private sector for tuberculosis. In this program, the quality assured drugs were supplied by the National TB Program and the Indus Hospital in collaboration with IRD screened all the people that came to its doors, identified those with tuberculosis, and then initiated them on treatment, as well as then reported these patients to the National Tuberculosis Control Program. With the success of this, came forward and in 2016 asked the inter-hospital TB program to become the principal recipient on its grant for tuberculosis. Under this grant, a Zero TB Karachi was initiated. Karachi is one of the largest cities of Pakistan with a population of 22 million. The Zero TB activities were later expanded to Peshawar and Quetta, which are the other two very large cities in Pakistan, along with 32 districts under each grant. The Zero TB conceptual model was framed under search, treat, and prevent. Under search, we looked actively in both adult as well as pediatric populations for people who might have symptoms of TB. Once they were diagnosed, they were all initiated on appropriate treatment, and appropriate patient support was provided for treatment adherence and treatment completion. In these households where the TB patients were identified, their household contacts were systematically screened under the prevent umbrella and initiated on preventive treatment. In addition, airborne infection control measures were undertaken in the facilities where these activities were being initiated. This is a busy slide, but with a map of Pakistan. The map shows all the highlighted parts where the Zero TB activities were undertaken, both in the public as well as in the private sectors. And as I mentioned before, the activities included active case findings, both at the tertiary care hospital as well as in the communities. It included treatment sites for both drug-resistant and drug-sensitive TB. It included treatment sites for preventive treatments as well. And in the private sector, not only large hospitals were involved, but also small general practitioners were engaged to find patients with tuberculosis. So the active case finding approaches and models include, as I mentioned earlier, hospital outpatient clinics, where all the patients coming into these outpatient clinics were screened for tuberculosis. We held community-based camps where community activities were undertaken prior to the camp, and the communities were asked to come and actually get screened for tuberculosis. We also screened workers at the industries as well as vulnerable populations in the prison. All the people at all of these facilities were screened with digital x-rays fitted with CAD4-TB. And any person with a score of more than 70 were then further investigated for tuberculosis. For active case finding of children, as we all know, this is a difficult area for doctors, but we trained a large cadre of nurses as well as physicians in how to diagnose children with tuberculosis. The nurses were stationed at outpatient departments of large tertiary care hospitals, whereby all the children coming in to these facilities were screened for symptoms of tuberculosis. Anybody that was identified who might have possible symptoms were then flagged for the medical officers to take a closer look at, and the child underwent clinical evaluation and diagnostic tests. So with our active case finding activities in 3 Zero TB cities, 32 districts, with the help of 1,200 human resource, 55 mobile X-ray vans, and 70 fixed X-ray centers, we screened over 4 million people verbally for symptoms of TB. More than 1.5 million chest X-rays were conducted, and more than 61,000 patients with tuberculosis were notified to the National Tuberculosis Control Program. All the people that we identified were initiated on appropriate treatment. So the 61,000 included both the sensitive TB as well as the drug-resistant TB, and they were all initiated on appropriate treatment and management plans. For majority of those patients who were identified under the active case finding, contact investigation was undertaken at their household level, and those that were free of TB disease were offered preventive treatment. My colleagues Maria and Amin will go into depth of both the contact investigation and preventive treatment for drug-sensitive and drug-resistant tuberculosis in a little bit. So I would like to talk about communication strategies around Zero TB Pakistan for the next few slides. It's very important that when we undertake programs at this scale, that we have a proper communication strategy to go around for awareness of the population as well as the masses at large. The logo that you see, the fisted logo that you see, it says Our TB Mitao, which translates into Come Eliminate TB. This logo was created by our comms team after extensive consultations with the communities around the Indus Hospital. A number of focus groups were held, and the community itself identified the logo as well as the slogan that they wanted to see. And once this logo was identified, it was then used extensively on all the communication campaign as well as all the active case finding camps. And the community then identified with it and actually participated in these events. In addition to the logo, we utilized celebrities to lead the campaign and shape the branding. Over here, you see a photograph of this gentleman who is a sports hero for Pakistan. He plays cricket and was a captain of the national team as well. His name is Yunus Khan. He lent his face to the campaign, and actually his photograph was then put on all the vans, mobile X-ray vans that went out into the communities. So very easily recognizable. In addition to that, we undertook mass media campaigns for the television, and these focused particularly on the stigma associated with TB for women, as well as active case finding in the older populations, which who may or may not be able to access healthcare easily. In addition to those, and lastly, our leaders, our technical leaders of the program went in and to talk about tuberculosis and active case finding and prevention of tuberculosis on TVs and radios in different shows. The IRD and Indus, both these organizations worked very hard to actually develop and build a political will around this campaign. So what you see is in a photograph, on the bottom photograph, on the bottom left, our then president of Pakistan was with the National Tuberculosis Control Program Manager and the senior leadership of the Indus Hospital at the inauguration of the Zero TB initiative in Karachi. On the bottom right, you see a row of vans that were parked in front of a mausoleum. This is actually a mausoleum of the founder of Pakistan, who unfortunately died of tuberculosis. So the actual Zero TB initiative was launched at his mausoleum very strategically and for very sentimental reasons. And the above pictures show senior leadership of the province of Sindh, where a large number of our activities undertook. So we continued working with the governments to sustain the activities and to keep them engaged. Now I will hand over to my colleague, Dr. Maria Jaswal, to talk about the contact investigation and preventive treatment for drug-sensitive TB in depth.
Thank you, Dr. Hassan. I would now like to talk about our TB contact screening and prevention treatment program for household contacts of drug-sensitive TB patients. We started as an operational research study to assess the safety, feasibility, and implementation of shorter treatment regimens such as 3HP and 1 HP in programmatic settings. We also assessed the uptake and completion rates of 3 HP among vulnerable populations such as prisoners. Our program was the first of its kind due to lack of WHO recommendations in 2016 for prevention treatment for all household contacts. We had to start and develop all material from scratch. We designed SOPs for the program along with training material for all staff members. Staff was recruited and 2-day training was conducted for staff on TB disease, contact screening, prevention treatment, and adherence. Each staff was also placed with a trained clinician for on-job training. We met with all the relevant stakeholders and program was implemented with the support and collaboration of national and provincial TB control programs. We also designed the data collection tools and an Android app was piloted and rolled out. We designed customized process flows for individual implementation sites. As there was lack of understanding about the newer prevention treatment regimens for all household contacts, we gathered a group of clinical experts from Pakistan and other countries to guide the teams with clinical queries. We used 3 different regimens for prevention treatment. 6H is daily dosing of isoniazid for 6 months. 3HP is once weekly dosing offered for 3 months. It is a combination of rifapentine and isoniazid. 1HP is the shortest regimen available with daily dosing of isoniazid and rifapentine offered in combination. 6H has the advantage that it can be given to all age groups, while 3HP is contraindicated in children less than 2 years old for lack of clinical trials for the age group. 1HP, on the other hand, has recent recommendation and is given to contacts aged 12 years or older. This right here is the process flow that we had been following. It starts with the registration of an indexed TB patient. All household contacts for the patient are enumerated after connecting with index patient. All household contacts are screened verbally for TB symptoms under mandatory chest X-ray. After the chest X-ray, sputum sample is collected for all the contacts who are able to produce sputum to run the gene expert. After the investigations, the contacts are evaluated by a medical officer who diagnoses TB among contacts. All those diagnosed with TB are linked to the TB disease treatment program, while all those who are found to be free of TB disease are offered prevention treatment. We had trained counselors working in the program. They would counsel the index patients at baseline about mode of transmission of disease and importance of contact screening. All contacts are counseled at baseline, i.e. at the level of TPT initiation and at each follow-up visit at clinic. They are counseled about prevention treatment and its significance, along with the importance of adherence and completion. At 2 weeks of treatment, contacts are called by the program counselor to check for adherence and any adverse events they may be facing in order to guide them and connect them with clinicians at the health facility as needed. We had a custom-built Android application for data collection for contact screening and TPT. Data was entered at each point of contact with the patients and household contacts. Health workers, clinicians, and counselors would use this app to collect the data. Between October 2016 and September 2020, we offered 3 different regimens in our program. We started with 6H for all contacts, and there was 39% uptake of 6H among contacts, with 45% completing their treatment successfully. As 3HP became available, we evaluated more than 30,000 contacts, of whom close to 15,000 contacts initiated 3HP, which amounted to an uptake of 48%. More than 70% contacts completed their 3HP successfully. 1HP was not recommended by WHO till early 2020, and our program is one of the first programs globally to roll out 1HP in the programmatic settings. We evaluated more than 600 contacts for TB. More than 400 contacts started 1HP, amounting to an uptake of about 65%. We saw treatment completion of more than 90% with 1HP. The results of 1HP rollout have been published in the Lancet Child and Adolescent Health. Please do look it up. It can be seen that as the treatment became shorter and shorter, there was improvement in uptake as well as completion of TPT. As it is seen in the cascade that the uptake has been at 65% at max, we saw refusal at different levels of cascade. We divided our refusals into 3 categories. First refusal was at the level of disease evaluation. The most common reason for refusal was work or academic schedule and the waiting time at the hospital. Next level of refusal was at treatment initiation. Most common reason for refusal was lack of interest in TB prevention treatment by asymptomatic contacts or adverse events among household members taking prevention treatment. We have also seen contacts refuse treatment after initiation. The most common reason for refusal at this level was duration of prevention treatment associated with the medicines. This slide presents the adverse events associated with each of the regimens that were offered. 8% of the contacts who started 6H reported adverse events. In comparison to that, only 1% of contacts who initiated 3HP reported any adverse events. Adverse events were reported in less than 1% of contacts who initiated 1HP. All regimens that are recommended are safe and effective, but looking at the data, shorter treatment regimens are safer, with only 1% of contacts reporting any adverse events at all. We also implemented prevention treatment among prisoners across 3 provinces in Pakistan. We found more than 8,500 inmates as eligible for TPT. More than 8,000 prisoners were initiated on 3HP. Treatment completion was more than 98% among prisoners. From our experience, it can be seen that shorter treatment regimens can be safely and feasibly implemented in programmatic settings. We have observed higher uptake and treatment completion with 3HP and 1HP. Given the shorter treatment duration of 3HP and 1HP, these regimens should be considered for wider implementation to improve reach and impact of TB prevention treatment. Now I would like to hand over to my colleague, Dr. Amin Malik, to talk about his experience with prevention treatment for drug-resistant TB.
Thank you, Dr. Jaswal. Hi, everyone. Today, I will be talking about contact investigation and TB preventive treatment for drug-resistant TB. So as we saw, preventive treatment for drug-susceptible TB has been established and has been around for a long time. But there is limited evidence for preventive treatment and contact management of drug-resistant TB patients. Unfortunately, there is no clinical trial data as yet. There are a few clinical trials going on, but they will be reporting data later in this decade. The guidelines that are available do not provide any preferred regimen. Any data that is available is also from specific settings, mostly from either high-income countries or from settings with high prevalence of HIV. Most of these studies have limited sample size. The effectiveness of preventive treatment is not well documented, and the factors affecting adverse events are not very well known. So in this context, we carried out 2 contact tracing studies in Pakistan. One was in an urban setting at the Indus Hospital in Karachi, a cosmopolitan city. The other one was in a rural setting at Institute of Chest Diseases, Kotri. The objectives of both these studies were to assess safety and feasibility of drug-resistant TB preventive treatment in a programmatic setting, to assess effectiveness of preventive treatment, and to describe occurrence of adverse events and associated risk factors. We prospectively evaluated 150 households with TB patients, 100 from Karachi and 54 from Kotri. All household members living with these index patients were eligible for this study, and the duration of both these studies were 3 years. So during our studies in Karachi, we identified 800 household members from 100 households. Of these, 402 were eligible for evaluation. We evaluated 326 contacts. 3 were diagnosed with TB. Of the remaining contacts, 215 were eligible for preventive treatment and 172 or 80% started preventive treatment. The completion rate for preventive treatment was 70%. In Kotri, we identified 446 contacts from 50 households. 415 were eligible for evaluation. We evaluated 278 contacts, diagnosing 3 with TB. Of the remaining contacts, 175 or 64% started preventive treatment, and the completion rate was 84%. The findings from both these studies have been published, and the citation is given on the slide. Now I'm going to talk about the effectiveness of DRTB preventive treatment. We define effectiveness of preventive treatment as disease-free survival 2 years post-contact. To be able to estimate the effectiveness, we had to estimate the rate or risk of disease from the literature, as we did not have a suitable control arm in our studies. So we surveyed the literature and we found 6 studies that gave data to document the risk, either using incidence rate or the risk. Becerra et al. 2013 study was the best fit as a cohort study for our data, but we estimated the effectiveness using all 6 studies to define a range of effectiveness. So of the 172 contacts that started preventive treatment from Karachi, 2 contacts developed TB over 2 years of follow-up, for an incidence rate of 595 per 100,000 person years. Comparing to the literature using incidence rate, the effectiveness ranged from 50 to 71% for a pooled estimate of 65%. Using risk, the effectiveness ranged from 11 to 89% for a pooled estimate of 72%. So as can be seen, the estimated effectiveness from our study for DRTB preventive treatment was 65%. We also evaluated adverse events from the preventive treatment. We used the Division of AIDS of NIH grading table, and an example is shown on the screen. As you can see, there are 4 possible grades of adverse events, and we utilized all the clinical data that we collected during the follow-up visits to grade these adverse events. So of the 172 contacts starting preventive treatment, 36 developed any adverse event over 6 months of follow-up. The rate of adverse event was 7.9 per 100% months, and there was no grade 3 or 4 adverse event documented. The results from this analysis has also been published, and the citation is given on the slide. This survival curve shows that most of the adverse events occurred early on in the treatment, with majority occurring within 60 days of initiating treatment. And they differed by the companion drug that was used. So the regimen comprised of 2 drugs, a fluoroquinolone with either ethambutol or ethionamide. Ethambutol fared much better with lower adverse events, and the adjusted hazard ratio of ethionamide compared to ethambutol as a companion drug was 2.1. So our data and studies showed that DRTB preventive treatment is feasible to implement under programmatic setting. A fluoroquinolone-based preventive treatment is 65% effective in preventing disease development over 2 years. And this regimen is well tolerated, especially when combined with ethambutol as compared to ethionamide. Now I will hand over back to Dr. Hussain to take us forward in this presentation.
Thank you, Dr. Malik, for the presentation. I'm now going to talk about the impact and the cost effectiveness, because these are the 2 important things that are always asked about whenever we talk of the preventive treatment. So my first slide over here shows the impact of these zero TB interventions over a period of time. And there are very many lines here, but I'm going to take you through this graph. So the x-axis shows the number of years. The y-axis on the left-hand side shows the case notification, and on the left side and on the right side shows the resources that were input. So active case finding in this particular town of Karachi, for which the analysis has been conducted, has been ongoing for a number of years prior to the zero TB intervention that happened. But in 2016, I would like you to focus on the blue dotted line, which are the X-rays that were conducted for all adult populations, so essentially active case finding based on X-rays. And in 2016, you see a sharp uptake of this X-ray active case finding intervention. The yellow line underneath it shows the household contacts which were initiated on preventive treatment. And you see both those lines going up onwards from 2016. And as these lines go up, the green line, which is the case notification, adult case notification for TB, you see that line coming down. So what we have seen and observed is, as we increased the active case finding and as we increased the prevention treatment for the household contacts in this population and in this town, the case notification declined. So which shows the impact of these interventions, combined interventions. And this goes very much hand in hand with the WHO papers that have been published a while back, which shows that if both these interventions actually are implemented together, then we would see a decline in the case notification. The next question that comes in is, okay, yes, it's impactful, but what is the cost of these interventions? So I'm going to focus particularly on the cost of the household contact investigation and the cost of offering preventive treatment. So in our studies, what we see that there is a passive case finding, which is essentially when an index patient is identified, the index patient is asked by the doctor or the treating physician to bring the families in for contact investigation and to exclude TB disease for them, which is shown by the counseling on this bar with an arrow. However, there is no follow-up whether the families have actually come or not. So in our intervention, what we included was phone calls. So if the family did not come for evaluation, then a phone call was initiated. And over a period of 2 weeks, we waited for the families to come. And then a reminder phone call was again made. So 2 phone calls over a period of 2 weeks were made. If the family still would not come, then a household visit was initiated for these families. And once they come in, then the same algorithm as explained prior is followed, that symptomatic evaluation followed by gene expert and chest x-ray, and anybody found with the TB disease is then put on treatment. So we actually went ahead and costed out the additional efforts required for the phone call and the home visits. And what we see is that it takes about $46 in the passive case finding arm, which is the standard of care, per index patient to contact trace the household members for tuberculosis in this population. And if we just take our baseline data, so using this amount of money, we only found 21 cases of tuberculosis over a period of 1 year. When we introduced phone calls and we initiated phone calls to all those family members who did not come for evaluation, we added in a cost of about $30, but ended up finding 102 patients additional in the arm, which we call the enhanced arm. So it was passive plus enhanced, which was the addition of the phone call. And then for the families that still did not come with the phone call, we actually initiated a household visit for an additional cost of $40 in addition to what we had already spent up to the enhanced part, and found another 53 patients through that active case finding and the household visit through that portion. So as what we see from this slide is that as we put in more effort into finding patients, we do find them. And if the countries are willing to put in a little bit more towards finding these patients who are still within the households, then we can easily approach them at a cost, but a cost which should not be non-affordable. So once the household members are actually free, we have identified all of those with TB disease and started them on treatment. The rest of the household are then offered preventive treatment. And as Maria pointed out earlier, we started with, we offered 3 regimens, of which we have been able to cost out 2 regimens, that is provision of 6 months of isoniazid, and compared it to 3 months of rifapentine and isoniazid combination. And what we see is that our cost per completed course for 6H is over $300, whereas The ones for 3HP are actually close to $400, and whereas that for 3HB is $290. So what we do see is, or what we do hear is that rifapentine is extremely expensive, so we should not be talking about that. But in our experience, what we have seen is that the cost of actually delivering this care is much, much more. And the graph here shows that. So the blue bars are the cost of the isoniazid, and the orange bars are the cost of the 3HP. And on the x-axis, what you see are different categories that we costed out. So in this, what you see is the medication is actually a relatively very small proportion of the overall cost. Majority of the cost was actually the clinical staff that delivers these services to the people, to the household contacts, and also the electronic medical record system. In addition to these costs, the families themselves incur a fair bit of costs to come to the facilities, pick up their medication, have a clinic visit. And what we observe is that with 6H, because it is a longer duration, the cost to the families and the expenses to the families are much higher than those that took 3HP. So overall, even though the drug isoniazid is much cheaper than rifapentine, but in order to deliver these services, and if we add the completion rates to it, we see that 3HP fares much better than 6H. And the results of this study have also been published, and the citation is available on the slide. So this is one of my last slides, and if I bring all the slides together, so the take-home message for us, from us to everybody, is that shorter preventive treatment regimens are safe and can be easily implemented, both for the DR as well as DS-TB. At scale prevention treatment, along with active case finding, has a population level impact, as we saw in the slide that I presented. But we also need to ensure that there is a good political will and there is a good stakeholder engagement to keep the momentum going at the country level. There is obviously a need for further research because we do see there are areas where in the cascade where we lose people. And so there is a need to understand why do we lose people? And also, if possible, there are to shorten the DRTB preventive regimen from 6 months to perhaps 2 months or less. Lastly, I would like to acknowledge all the partners, our donors, and our different partners who have been engaged with us over these interventions and have supported us throughout. Thank you very much. And I would like to pass the microphone back on to Dr. Becerra.
Thank you very much, Dr. Hussain, Dr. Malik, Dr. Jaswal, for this very, very inspiring presentation. And I want to thank all the viewers for joining us. We invite you to join the live question and answer session that will be held on April 8th. Please look at the link and register there. That'll be here below. And also do send your questions ahead of time so that can facilitate getting into the discussion on April 8th. See you that day. Thank you all. Bye-bye.